Hello, everyone. Welcome to Appetite for Discussion TT. I'm Karen Das, and thank you for joining us for this new episode, a new series in our cancer conversations. And many of you would have been able to capture some of our conversations before. Those were audio versions, and those episodes are on Spotify, by the way. So you simply search Appetite for Discussion TT, and you'll see a list of fascinating topics regarding cancer. But it's all about taking care of health. And so we've decided, Dr. Akash, Maniam, and I, we decided that we will try a different format. And so we are working with a video format. And this is an opportunity for you to see the oncologist yourself, because we've been hearing him for a while. So oncologist, he practices in the UK, but he's also a clinical director at the Caribbean Cancer Research Institute, the CCRI. Dr. Maniam, it's so good to see you.
It'll take some time to get used to this.
I know.
Thanks for having me again. It's good to be here.
All right. So just briefly, for those who are probably catching these for the first time, tell us about the CCRI.
Sure. Thank you. And thanks for the introduction. So, as you said, the CCRI is the Caribbean Cancer Research Institute. It used to be called the Caribbean Cancer Research Initiative. So if you heard that name before, it's the same thing. So we are essentially a non-profit organization for a group of motivated volunteers who really just want to improve access to cancer care in Trinidad and to generate research, because it's an area that is sorely lacking. When it comes to access, the main facets of what our organization does would be empowerment of patients through information, education, awareness. Secondly, navigation, which is a topic in and of itself, but essentially we train navigators and we try to raise awareness of the role of navigation in optimal cancer care provision. And finally, we aim to provide access to information and specialized services free of charge if people wish to reach out to us just to get information. We have a range of professionals who can at least address queries and direct you. So it's completely free. You can just access us via our website, ccrinstitute.com. And on that website, you can check out our mobile number or, web chat and our WhatsApp information. Just reach out to us, and anything you need, we'll try to help.
Well, thank you so much to the CCRI for loaning us your clinical director so that we can have these episodes running. Today, we want to talk about breast cancer surgeries. Now, we covered the topic of breast cancer previously, but it's important that we return to breast cancer. And in this episode, we talk about the surgeries. Now, many of you, just like myself, when you hear breast cancer and you hear surgery, what's the first thing that comes to mind? Not a mastectomy? For many of you, yes, mastectomy or a double mastectomy. But that's just one type of surgery. There are other types of surgeries. So then the questions would be, how do I know which one I would need? Well, this is where the oncologist will come in. Also, if it's not a mastectomy or double mastectomy, is that where it gets really bad? And how do I avoid a mastectomy or a double mastectomy? And also, what are the side effects? What is the success rate? There's so many questions when it comes to surgeries in the general, but let's talk about breast cancer surgery. So Dr. Maniam, well, how about you share with us the different types of breast cancer surgeries?
Yeah, sure. Happy to. You're absolutely right. I mean, historically, mastectomy was, if not the only thing, it was the mainstay of breast cancer surgery. So I'm not surprised that most people would still associate breast cancer with mastectomies. It's going to take some time to change that. And I'm hopeful that with this session, we can at least broaden people's awareness of what breast surgery can entail. So let's keep it very simple. The two main types of breast cancer surgery are mastectomies, as we've discussed, which involve removal of the entire breast, or a lumpectomy, sometimes called a wide local excision, etc. But really, it's a more localized surgery, a smaller form of surgery where you're removing the lump, in this case the breast cancer, and a small rim of tissue around it to get a clear margin. Those are the two main types of breast cancer surgery across the world.
Are we seeing an increase in certain types of surgeries or decline in other types of surgeries?
Yeah, I think since mastectomies were the backbone of breast cancer surgery, as we've understood the biology of breast cancer more, as screening has been implemented, as awareness has been improved, as early detection and diagnostics have been reformed, we're definitely seeing a shift towards more minimally invasive surgery as a whole across cancer types. So breast cancer, we're definitely seeing more lumpectomies than mastectomies than we used to. Now what we're really seeing is a better understanding of who needs a mastectomy and who can have a lumpectomy. So I don't want anyone to leave here thinking one is better than the other. It's not that simple. It's more which is more appropriate for the case in front of us. And we should not just assume that you need a mastectomy or you have to have a lumpectomy. It's just trying to figure out which one is beneficial. And that conversation you should absolutely have with your breast surgeon, your oncologist, whoever's treating you at that time.
You know, there's a thinking that if it's affecting a particular area in your body, and in this case the breast, just if you remove it, then it disappears. And you don't have that problem again.
It's absolutely the thinking. It's what we see very commonly. And I would say if we take other cancers like bowel cancer, colon cancer, you would very rarely have to remove the entire bowel to deal with cancer in one area. You would just remove that part of bowel and the rest of your bowel would be there. Same with if you had skin cancer, say a melanoma in your foot. You wouldn't normally take out the entire foot or the entire leg. You would take out the area of skin. So when it comes to breast cancer, we really want to understand that just because there is cancer in one area of the breast, it doesn't mean the entire breast is cancerous or the entire breast is bad. And it certainly doesn't mean the other breast is cancerous. It also doesn't mean that having them both removed, a double mastectomy, as you've said, means that it will never come back. It is a lot more rich and nuanced than it used to be, where we just think in black and white terms that, okay, it's bad, cut it out. It's not the be-all and end-all. It's a lot more about the biology, the patient fitness, their preference, of course, reconstruction, the biology of the tumor, and the stage. Those are the sorts of factors we have to think about when deciding what sort of surgery to offer someone.
But let's just say a patient has been diagnosed with breast cancer. They start chemotherapy. If you're on chemotherapy, would you need any of those surgeries?
Often, yes. If it is curative, so if the breast cancer is early, let's say it has not spread far away to the lungs, the bones, the liver, or to lymph nodes far away from the armpit or around the breast. Generally speaking, if you're having chemotherapy, the aim is to consolidate that with surgery afterwards, or vice versa, to have surgery first and chemotherapy afterwards. So in curative settings, it is still the norm, the standard, to have both, at least both, and sometimes radiotherapy, quite often radiotherapy as well. So again, we wouldn't want to say one treatment is better than others. Often for breast cancer, you need 3, 4, 5 different types of treatments at different times to address it. So it's about sequencing and deciding which one is the most appropriate at each stage, not to overtreat by taking off more healthy tissue than you need to, but also not to undertreat by giving you less treatment than you need in order to reduce your risk. That's the balance that we're trying to strike, and those are the conversations we want patients to have.
What sort of questions do you get asked most often by patients?
So when patients come to us and we're giving them chemotherapy before surgery, the most common question, as you said, is, do I still need surgery afterwards? And the answer almost universally is yes, you still need surgery afterwards. And we'd always defer to the breast surgeons to decide exactly what type, but we would encourage patients to talk about it with them. Secondly, again, what you've said before, let me just have a mastectomy, let me just have a double mastectomy. I don't want to deal with this anymore. I don't want to see the breast anymore, because in some women's minds, there is a stigma attached to that breast. It is seen as diseased. It is seen as something that needs to be removed, especially in the Caribbean. Culturally, that is a very common perception. So quite often you'd be asked, well, when we're finished with this, I just want to have it all out. And we'd say, well, hold on, have the conversation with the surgeons, and let's see if they can, explore this in more detail. The third question definitely is about, for those who are aware of the choices, they want to know two things. They want to know about risk of recurrence and effectiveness of each option, and they want to know about the side effects, as you said, the complications of each operation. People would think a mastectomy has a lower risk of recurrence than a lumpectomy. That has not been proven to be true. The data is very clear that a lumpectomy, often requiring radiotherapy afterwards, not in all cases, but in many cases, it's at least equivalent to having a mastectomy with or without radiotherapy. There is some data that says it might be better, but I think for simplicity's sake, we can regard them as equivalent. They're both very good options as far as mitigating against the risk of relapse is concerned. They're both very good treatment options. So if it is technically feasible, i.e. if the surgeon feels that it is appropriate to perform a lumpectomy, then it is entirely appropriate to have one. The risk of recurrence is the same. Now, that is not going to be true for everyone, and there'll be some women who cannot have a lumpectomy for various reasons.
What are some of the reasons why a woman would not be able to have a lumpectomy?
Good question. So there are certain things that we just have to consider. If we're thinking about someone's history, say a woman has had breast cancer before and they've had radiotherapy before, 5 years ago, 10 years ago, and the cancer's come back in the same breast. Quite often you end up going for a mastectomy because you cannot give more radiotherapy to that area, for example. If the tumor is very large relative to the size of the breast, and you can't just cut around it without significant scarring, then a mastectomy often would be used. Generally, the more advanced the cancer is, the more likely it is that a mastectomy will be offered. For instance, if there are several different tumors in the breast, what we call multifocal breast cancer, you may have 2, 3, 4 different breast cancers in that area, you may not be able to get away with lumpectomy. If, for example, you have a genetic mutation that makes it very likely for you to have more breast cancer in the future, for example, BRCA1 or BRCA2 mutations, then quite often, not always though, but quite often it would favor a mastectomy, because then you are at very high risk of developing more breast cancers in future. So those are some of the reasons. And sometimes you have a lumpectomy and the lumpectomy didn't get everything. The margins were what we call positive or involved, and you just have to go back in again and take more, because sometimes the cancer is more advanced than you initially think. And of course, patient preference. Some patients don't want to have a lumpectomy. Some patients would prefer not to have radiotherapy, because sometimes you can avoid radiotherapy with a mastectomy. Not always, but sometimes. So some patients would prefer not to go down that road. Mm-hmm. Those are the main reasons generally why one would choose a mastectomy over a lumpectomy. For everyone else, you would, where possible, offer a lumpectomy.
And what about side effects of a lumpectomy?
Much milder in general. A mastectomy is a much bigger surgery. There is a longer recovery time than with a lumpectomy. And you're more likely to have longer term nerve damage. So the sensation around the area might not be as good, because you have lots of little nerves around there. You might have pain or tightening or burning or just odd sensations sometimes years later. With a mastectomy, it's a bigger wound. So you may have more issues with infection or wound healing or oozing afterwards. Most breast surgeons now are really good, so the surgeries are both quite safe. It's not to discourage, it's just we're looking at one surgery being more invasive than the other. And A mastectomy is more likely to require reconstructive surgery afterwards, because with many lumpectomies, you can still have a lot of symmetry between the breasts. You might just have a small amount of tissue taken out. With a mastectomy, you have one breast on one side and no breast on the other side. So, at least here in the UK and in many other countries, we would offer reconstructive surgery to all. And that is obviously a more difficult process that involves further surgeries and longer term risks associated with reconstruction, because it's a lifelong process. So, generally speaking, lumpectomies have shorter recovery times and are more minimally invasive. However, because lumpectomies more often require radiotherapy, you will then have the side effects of radiotherapy to contend with, which is generally, radiotherapy is generally well tolerated, but you could have, skin darkening or sunburn-like burns over the area, etc. So it is a balancing act, but lumpectomies and radiotherapy are generally very well tolerated by most people. So are mastectomies, but there is a higher rate of issues.
How long does a lumpectomy, the surgery, take on average?
As a non-surgeon, I don't want to step on their toes and say too much, but I guess from our experience here, a lumpectomy is a shorter procedure. They're both same-day procedures, but you're talking about maybe a couple of hours versus a bit longer. A lot of it depends on how things go on the day and on the table itself. But usually a couple of hours, I would say, for a lumpectomy.
Let's talk about the other types of surgery. Now, the mastectomy keeps coming up, and I'm wondering if this could also be one of the reasons why some people would opt for mastectomy, is because you just want to avoid the radiotherapy, which we mentioned just a while ago.
It is. At the end of the day, I'm not going to advocate that one is better than the other, but I'm a big advocate for informed choice. So I just think that when a patient is diagnosed with breast cancer, male or female, of course, because we know men can get breast cancer as well. It's just in men, it's a bit harder to do lumpectomies because men have much less breast tissue generally, which is why we haven't talked about them. But in general, for me, the main thing is just informing the patient. Look, you can, if you're eligible for both, say, well, if you have a lumpectomy, you will need radiotherapy in this case. If you have a mastectomy, you won't need radiotherapy in this case, most likely. These are the risks and benefits of a mastectomy. These are the risks and benefits of radiotherapy. These are the long-term outcomes and the long-term complications. Take a few days, take a week, think about it. These are not usually decisions that you need to make in a day or in a clinic. You can think about this for weeks often. So it's just good to get this information. And sometimes you might even just see a radiation oncologist before you have your surgery, just to find out about what radiotherapy would be like afterwards, to help make that informed choice. I just want people to take away from this session, ask those questions and have those conversations. Don't just go into one with a preformed opinion thinking that it's clearly superior. The data doesn't show that.
Right. So there's the oncologist, and that would be you. But then you have a radiation oncologist?
So generally you have three different types of oncologists. You have surgical oncologists who do the surgery. So in this case, the breast cancer surgeons would be breast surgical oncologists. You have the radiation oncologists, sometimes called clinical oncologists, depending on which country they trained in. They would be responsible for the radiotherapy, and sometimes they will do chemotherapy, etc. Then you have the medical oncologists like myself, and you would deal with the systemic therapy, so chemotherapy, endocrine therapy, targeted therapy, etc. And for breast cancer, you usually need a combination of all three to be able to manage just one condition properly. Wow. Most of the time, you need to see all three to deal with it. So that's why we all have awareness of what the others will do, because we work so closely together. But at each point when we're seeing them, it's really just making sure that they don't go into the next step blind. They know they have choices, they know that they can discuss. And if the surgeon says, look, a lumpectomy is not possible for X, Y, and Z reasons, that's why I recommend a mastectomy. That's an informed choice because they've explained why. But if someone just says, just have a mastectomy because, or the patient says, I want a mastectomy, that's it. That needs a little bit more discussion.
Yes, because I suppose the patient will be coming from an emotional state, which doesn't always mean that you're thinking logically about something. So it's important that you have that conversation with the relevant specialist. And then we brought this up in previous episodes as well. It's important that you also have this conversation with members of your family so that you don't feel the full pressure is on you and you alone to make this decision, so that you share it up a little bit. You keep it within your circle, of course, because you don't want that people tell you, well, you really should do this, because we're in Trinidad, so we know that kind of culture where everybody's an expert on something, other than the real experts. So we don't want you going to the wrong people for information. They may have your best interest at heart, but again, you need to discuss this with the relevant staff people. All right.
I would add to that. It's important to discuss, but don't let anybody persuade you. It's your breast, your choice. And when we're talking about the side effects of mastectomy, any breast cancer surgery carries a psychological, sexual, and social profile that you might not be aware of until you're finished with everything, or you might not even think about it until maybe 5 or 10 years, 20 years later. But your whole life changes after any surgery. But after a mastectomy, the things that you might not think about at the time when you're just thinking, oh, I have cancer, I need to treat it, I need to treat it, I need to treat it. And as you said, it's an impulsive, emotional, it's a primal response we all have. Mm-hmm. You don't think about what kind of bras will I need to wear? Can I wear swimsuits afterwards? What will my relationships look like with my spouse, with other people? These are extremely important things for self-image, for confidence, for mental health. And we want to cure cancer. We don't want to cause depression and social withdrawal. And there are lots of cases of divorce and marital strife after these sorts of operations, because they are body changing, they're image changing. In some ways, having a piece of bowel removed, a lot of that is internal. But having the breast removed is external, and it's something that you'll have to look at every day. You need to be comfortable with the choice and well supported. So discussing it is critical, as you said, but ultimately you have to be comfortable with the decision, and everyone should support that.
Oh, absolutely. So we spoke about recurrence with a lumpectomy. So let's talk about recurrence and mastectomy and double mastectomy.
Well, in most cases, a mastectomy or a double mastectomy would not add anything meaningful to the risk of recurrence. Even after mastectomy, the cancer can come back in the skin, the chest wall, even in the scar. It can come back even if you've had all your lymph nodes removed. It can come back under the armpit. So it doesn't necessarily reduce the risk at all. And when you're performing a lumpectomy and giving radiotherapy afterwards, you're trying to equalize that risk, because you're treating the normal healthy breast tissue around the surgery to reduce that risk. So the risk of recurrence is pretty much the same. There are some factors like genetic mutations we've discussed, where if you've had a lumpectomy, if you've chosen to have a lumpectomy but you have a BRCA1 or BRCA2 mutation, for example, then there are higher risks and you'll need closer surveillance, etc. But in general, for the vast majority of women, you can just look at it and say, lumpectomy, mastectomy, it's the same. A double mastectomy, one really would not recommend that to the vast majority of women with breast cancer. There is no added benefit in taking both out.
Well, there might be the thinking that the cancer has gotten really bad in order for you to have a double mastectomy.
And that's the thing. I don't want to associate mastectomies with bad cancer. Let's look at it more from a biological standpoint, because if you have a very small type of breast cancer that's very aggressive, let's say triple negative breast cancer, which is very aggressive, and you have a lumpectomy, you have a higher risk of recurrence than a very large hormone receptor positive tumor that had needed a mastectomy. So they may have just done the mastectomy because the tumor was too large and they couldn't do a lumpectomy. But you'd be more afraid of the triple negative breast cancer even though they had a lumpectomy. So it's not about having bad cancer and therefore having bigger surgery. It's not about that at all. It's about patient choice, patient factors, and surgical choice based on what is most appropriate. So I don't want anyone to associate one type of surgery with better or worse cancer. It really is just, what is the least amount of surgery I can do safely?
Just talk briefly about reconstructive surgery. Who does that?
The breast surgeons can do it, and they would then be called oncoplastic surgeons. Onco from oncology, and plastic surgeons. I think most people would know of as surgeons who would deal with reconstruction in various parts of the body. But reconstruction is a complicated area. It is a very important area, and it should be offered to all women who have a lot of asymmetry, so a mastectomy for sure. They should be offered reconstruction, but not every woman is suitable or eligible for reconstruction. A lot of that, again, depends on, obviously, patient choice, but also patient factors, based on if you have other medical conditions, for example. Sometimes if you're a heavy smoker, or you have heart disease or diabetes, sometimes you might not. If there are weight issues and you need to lose weight, sometimes you need to lose weight before having reconstructive surgery. Sometimes if you've had radiotherapy very quickly or chemotherapy, it can change the reconstruction. So if you have radiotherapy after an implant, sometimes you can have what we call capsular contracture. If you have an implant, it can get tight afterwards. So it's not for everyone, but it should be offered and discussed as a general rule. And there are generally two types of reconstruction. You can use implants, which I think most people are aware of because that has been the case for decades. For cosmetic reasons, many women had breast implants. And you can have what we call autologous reconstruction using the person's own tissue. So you can take tissue from the lower abdomen, from the thighs, from the buttocks sometimes, and reconstruct a breast. And that is often more natural feeling because it's your own tissue, it's warm, it has its own blood supply. But all reconstruction should be seen as a long-term. For example, if you have implants, they will often need to be changed around every 10 years. Sometimes they rupture, depending on the type of implants, about a percent of them would rupture every year. Sometimes you have adverse reactions to the type of implant because it is a foreign substance. So, and obviously an implant is not a natural breast, and while they try to make it as close to the other breast as possible, it's never going to be perfectly symmetrical. And sometimes you may even need further surgery on the other side to what we call symmetrize, to get both sides to be around the same. But either way, you will often need longer term surgical follow-up and repeated operations, later on. So it should be seen as a long-term process rather than just a one-size-fits-all. You have a reconstruction, everything is completely normal.
And even after that, do you still need to stay in touch with your oncologist?
You need to be in touch at least with somebody from the team that treated you. If they're very early breast cancer, sometimes you can stay under the surgical oncologist. If it's more advanced and they're on long-term treatment after surgery, they will stay under the medical oncologist. But at least for 5 years after surgery, it's very important for you to have follow-up with an oncologist, or at least an oncology team that deals with it, and access to your nurse specialist if available. And then obviously screening longer term. After the 5 years have finished, you will still need screening for recurrence of breast cancer or new cancers.
So we have many more episodes coming your way via YouTube and other video formats. So we also have our audio version available on Spotify, Appetite for Discussion TT, so you can check those episodes there as well. And so the conversation continues on cancer. We know that it's a heavy topic, and a lot of folks don't like to hear that word cancer because it's a frightening word, but we don't want you to be scared. We want you to be empowered. We want you to be properly well informed so you can make proper choices in life, and you have access to so much information, and information is good because knowledge is power. All right, so we look forward to joining you for another episode of this cancer series.